Hi everyone, let me give you a scenario. Imagine you had chicken biryani from your mess and from the very next day you get vomiting, diarrhea and abdominal cramps and you call your batchmate for replacing you at the duty but he's telling the same set of symptoms. When you ask other friends of yours, you again find that many of them are experiencing similar set of symptoms. So here comes the importance of learning about outbreak investigation. So, what is an outbreak? We'll see it today. What else we will see? What is the role of epidemiology in an outbreak? Who should respond to an outbreak? And what are the steps in investigation of an outbreak? So, if there is a case of common cold, will we start outbreak investigation immediately? No. But if there is a case of yellow fever, will we start an outbreak investigation? Definitely, yes. This is because there are some diseases which are so rare in a given population that even a single case warrants an epidemiological investigation. Whereas there are diseases that occur more commonly, so that only deviation from the norm warrants an investigation. But there are different terms like sporadic, endemic, hyperendemic, epidemic, outbreak, cluster, pandemic. What are all these? What are the differences between all this? I know many of you watching this video might be aware of it, but let me help you in quickly brushing up your memory. First, sporadic. What is an sporadic? Sporadic refers to a disease that occurs infrequently and irregularly, which means there is no fixed pattern. Then what is endemic? Endemic refers to constant prevalence of a disease or an infectious agent in a population within a geographical area. For example, Kala Azar is endemic in Bihar. What is hyperendemic? Hyperendemic refers to persistent high levels of disease occurrence. Then what is meant by epidemic? Epidemic refers to a sudden increase in the number of cases of a disease above what is normally expected in that population in that area. Okay, two key points here. Epidemic refers to sudden increase in the number of cases. So sudden increase is the first key point. Above what is normally expected is the second key point. Okay, so this is an epidemic. Outbreak carries same definition as that of an epidemic, but here outbreak is more limited to a geographical area. For example, food poisoning outbreak which occurred in February 2021 at AIIMS Patna. Okay, then what is meant by a cluster? Cluster refers to an aggregation of cases grouped in time and place. But the key difference between a cluster and an outbreak is that in an outbreak, we know what is the expected number of cases. But whereas in a cluster, we can comment an aggregation of cases as a cluster even when we do not know what is the expected number of cases. Okay. What is a pandemic? Pandemic is an epidemic that has spread over several countries or continents, usually affecting a large number of people. Example, COVID. So, we have seen all the differences. And what is an outbreak? Outbreak is a sudden increase in the number of cases above what is normally expected, usually in a limited geographical area. Okay. So, here it's the same thing which I am trying to depict. You can see in endemic, it is like constant prevalence of a disease in a particular region. Epidemic is sudden increase above what is normally expected, and in pandemic it is spread across wide region, across different countries or continents. Okay, so if an outbreak occurs, for example, if there are many cases of food poisoning at your hostel, why should you bother in first place? Why can't you leave just as it is? Okay. In other terms, what are the objectives of outbreak investigation? The first objective of outbreak investigation is to define the magnitude of outbreak, to find out the cases of outbreak, and the third point is to identify appropriate control and preventive measures. Okay, here comes the next question. Who should respond to what? Should WHO respond if there is a case of food poisoning at your hostel? So, there are preset trigger levels for diseases that are identified with specific responses at various levels. Okay, so the levels depends on the epidemic potential, case fatality, and prevalence of the problem in the community. Okay, now let us see what are the three trigger levels. Trigger level 1 is that if there is a suspected or a limited outbreak, then it warrants a local response. If there is an epidemic, it's trigger level 2 and it warrants a local and regional response. If it is a widespread epidemic, then it is trigger level 3 and it requires local, regional and state level response. Okay, we should always have a fine balance between the investigation and control while responding to an outbreak. Okay, for example, when the etiology is known and the source is known, then we should focus more on control. When the etiology is known but the source is unknown, then we should focus more on investigation. When the etiology is unknown and the source is known, then equal importance should be given to both control and investigation. When the etiology is unknown and the source is also unknown, then more importance is to be given to investigation. In simple terms, we should focus more on investigation when the source is unknown, and we should focus more on control when the source is known. Okay. Please note that in non-endemic areas, even one case of suspected epidemic-prone disease should initiate a trigger response. Example, yellow fever. Okay. Whereas in endemic region, change in pattern of diseases or evidence of clustering of diseases should be considered as a trigger event. Okay. In disease control the only goal of an outbreak investigation? Absolutely no. Outbreaks are a great opportunity to learn. We cannot decide who gets exposure to COVID. We can take advantage of what has already happened and learn from it. It is a kind of natural experiment. We can use this as an opportunity to characterize the natural history of disease even if we know the disease in and out. Outbreak investigations provide additional knowledge by assessing the impact of control measures and usefulness of new epidemiological and lab techniques. Okay. Apart from disease prevention and control and the research activities, is there any advantages? Yes. Outbreak investigations is sometimes necessary to address the political or public or legal concerns. For example, if the residents of Fulbari are complaining that establishment of a new factory in the locality is the reason for increase in number of diseases, number of cases of particular disease, and even when you know that this is epidemiologically unlinked, we can conduct an outbreak investigation to address the concern of the public. Similarly, this outbreak investigation will help us to identify populations that have been overlooked and to help in identify the failures in intervention strategies. It can be used to evaluate program effectiveness as well as this is a wonderful training opportunity. Let me summarize it again quickly. When there is an unusual event, see whether it is an outbreak. The answer can be no or yes. If it is an outbreak, then find out whether the sources and modes of transmission are known. If yes, then go for control measures. If not, then investigate with the help of a clinician, microbiologist, and an epidemiologist and try to formulate hypothesis by describing the time, place, and person. When your hypothesis fits the fact, then go for control measures. When it does not fit the fact, then go for analytical investigation. Okay. So, again, we get the important question, who should respond to an outbreak? At the PHC or CHC level, the medical officer in charge of that hospital is responsible for responding to an outbreak. Okay. At district, state, and central level, we have special rapid response team which are formed to investigate an outbreak. Okay. If an outbreak is suspected, the local health team should verify it, and once this is done and there is a need to investigate, then the rapid response team needs to take over. Okay. What is basically a rapid response team? Rapid response team is a multidisciplinary team that looks into various aspects of an outbreak. The team has an epidemiologist, a clinician, a microbiologist, and other specialty people as per the requirement. What is the job of this RRT, that is rapid response team? The primary job of rapid response team is to examine and investigate the outbreak episodes. They follow all the 10 steps in every epidemiological investigation. Frequently, epidemiological investigations are done after the peak of the epidemic has occurred, and in such cases, the investigation is mainly retrospective. We will learn more about the study designs in the upcoming slides. Okay. No step-by-step approach is applicable in all situations. Doing all the steps of an outbreak investigation is essential, but it is not mandatory that the sequence which is being recommended should be followed as it is. Okay. So, what should we know for conducting an outbreak investigation? Before moving to the steps of an outbreak investigation, let us discuss what all we need to know about before an outbreak investigation is started. We need to have the knowledge about the diseases, the clinical signs and symptoms and pathological changes. Then we should have knowledge about the etiological agents, types of agents and diseases caused and lab tests to assess the presence of agents. Next, we need to have knowledge about the outbreak characteristics for specific diseases, like the incubation period for biological agents or the induction period in case of a chemical agent, the mode of transmission, the socio-demographic susceptibility, All these you should have knowledge about. After that, we need to have knowledge about the potential risk factors or the high risk situations. We should have knowledge about the environmental and food sanitation practices, immunological susceptibility, sources of exposure, etc. When we have knowledge of all these, it will help in conducting the outbreak investigation and derive meaningful results from it in a much better fashion. Okay, so there are 10 steps in outbreak investigations. They are: first one is to determine the existence of an epidemic or an outbreak. The second step is to verify the diagnosis. The third step is to define a case. The fourth step is to search for a case. The fifth step is to generate hypothesis using descriptive findings. The sixth step is to test the hypothesis based upon analytical study. Seventh step is to draw conclusion. Eighth step is to compare the hypothesis with established facts. Ninth step is to communicate the findings. And our last step is to execute preventive and control measures. In addition to all these 10 steps, we have 3 more steps given by CDC. Okay, the first step according to CDC is preparation of fieldwork. And after the sixth step, which is the testing the hypothesis, CDC is recommending another step, which is reconsideration or refinement or re-evaluation of the hypothesis, and it's given as a separate step. Okay. Similarly, initiation and maintenance of surveillance is considered as a separate step. Okay. Instead of these 13 steps, we will stick to the 10 steps given in this slide for ease of remembrance. Okay. However, I'll try to cover up the extra 3 steps in a combined fashion with the other steps. Conceptually, control measures comes after the hypothesis has been confirmed. But in practice, control measures are usually implemented as soon as the source and mode of transmission are known, which may be early or late in any particular outbreak investigation. So, I mean to say that not all the steps are strictly followed in a particular sequence. Okay, we'll see the first step now, which is determining the existence of an outbreak. So, what was the difference between outbreak, epidemic, and cluster? Once again, epidemic refers to sudden increase in the number of cases of disease above what is normally expected in that population in that area. Outbreak carries the same definition of epidemic, but it is often used for a more limited area. Cluster refers to an aggregation of cases grouped in place and time that are suspected to be greater than the number expected, even though the expected number may not be known. Okay. How to know if a cluster is an outbreak? Okay. So, one of the first tasks the epidemiologist has is to verify whether a cluster is an outbreak. Here, the observed frequency is compared with the expected frequency. How can we get this expected frequency? It is the number which we get from the previous few weeks or months or a comparable period during the past 3 years. Okay. So, what is the threshold we generally keep to call it as an epidemic? We have an arbitrary limit of 2 standard errors from the endemic occurrence. When the number of cases crosses 2 standard errors, then we consider it to be an epidemic. The next question which always arises is that whether excess cases always means an outbreak. Actually, when the reported number of cases is more than the expected number, it does not meaning an outbreak always, because it can be due to many reasons. For example, it can be due to change in local reporting system, it can be due to change in case definition, it can be due to change in increasing awareness, or it can be due to improved diagnostics. So, all these things we need to keep in mind before declaring an outbreak, or like before raising a false alarm. Okay. So, does a single case always mean an outbreak? As I said earlier, even a single case could mean an outbreak in case of rare diseases. For example, when there is a suspected case of plague, then even a single case is enough to call it as an outbreak. Okay. So, what are the factors influencing decision making? All these times we were talking about the number of cases. So, apart from number of cases, there are various factors like severity of illness, potential of spread, availability of control measures, political considerations, public relations, availability of resources. All these are the different factors, various factors based on which we make the decision whether to conduct an outbreak investigation or not. Okay. So, based on all these, we will be conducting an outbreak investigation. But along with this first step of determining the existence of an outbreak, we may need to prepare for field work as well, which is a separate step. There may be different scientific issues, investigative issues, management issues, operative issues. We should anticipate all those in advance and plan accordingly. We should plan everything in a very nice way. For example, if you are going to conduct an outbreak investigation for COVID, then we need to arrange the PPEs to protect ourselves, arrange the materials for sample collection, sample storage, transportation. We should keep the checklist or performer ready. We should have a clear plan of action. We should have mobile phones and laptops for data entry. If internet connection is needed, what we are going to do for it, who will be in my team, who is my team lead. We should visualize everything like what is step 1, step 2 and step 3 so that the whole process goes on smoothly. Okay, so what is the next step? The next step is to verify the diagnosis. Why this is needed? Because earliest report regarding an outbreak is often obtained from a health worker or a layman or from a media. Often the initial report does not contain the diagnosis, rather it contains syndromic constellation of signs and symptoms. For example, a outbreak of cases of fever and rash will be a news. Okay, so it is essential to verify the diagnosis of the condition which we are dealing with. So how can we verify this diagnosis? We can verify the diagnosis by doing a proper history taking, collecting the details about the possible exposures, then finding about the history of similar cases in the neighborhood or workplace. It is essential to record complete details. Verification of diagnosis is usually made on clinical, lab and epidemiological parameters. Okay, should we confirm all the cases then? Not necessarily, because during epidemics it's difficult to confirm all the cases, and even lab confirmation for 20 to 30% of cases would be adequate. Okay, what you could see here, this is a screenshot of a paper on outbreak investigation done by our department. What it is showing? It is showing the definition of case. Okay, so our next step is to define a case. We have seen the first step, which is determination of an existence of an outbreak. Second step is to verify the diagnosis. Now the third step is to define a case. Okay, so why do we need to define a case in first place? This is because when we are starting to search for additional cases, the process would involve many team members. To ensure uniformity among investigators during investigation, we should have a case definition of a case. For example, in case of malaria, we can have the case definition as a patient with fever who may be accompanied by headache, backache, chills, rigors, sweating, myalgia, nausea, vomiting, anemia, splenomegaly, convulsion, coma, shock, spontaneous bleeding, pulmonary edema, or renal failure. And this definition which we are going to give should be adequately sensitive as well as specific. What do you mean by adequately sensitive? It should include all those who are having the target disease. For example, all those who are having the malaria, though this might include few people who do not have malaria. Okay. Similarly, it should be adequately specific. It means it should exclude all those who do not have malaria, though many mild cases might be missed out. So, therefore, there must be an adequate trade-off between both sensitivity and specificity. Initially, during the initial parts of the investigation or while formulating the hypothesis, it is better to have sensitive definitions, and later during hypothesis testing we can have specific definitions. Okay, so for all practical purposes we can have three categories of cases. I remember by the mnemonic SPD. Okay, S is for suspect cases, P is for probable cases, D is for definite cases. For example, any case of fever in an endemic area is a suspect case of malaria. Similarly, any case that meets the clinical definition of malaria is a probable case, and those with lab confirmation is a confirmed case. Okay, so as where these cases are labeled and by whom? A suspect case is labeled at field level by a health worker. A probable case is labeled at health center by a medical officer, and one and a definite case is labeled at the or a confirmed case is labeled at the laboratory by a lab technician or a microbiologist or a pathologist. Okay, so now we have seen the first three steps. The first step is to determine the existence of an outbreak. The second step is to verify the diagnosis, and the third step is to define a case. What is the fourth step? The fourth step is to search for a case. Why do we need it? Because many outbreaks are brought to the attention of the health authorities by concerned health providers or citizens. But this is just the tip of the iceberg, because the number of such cases is small and unrepresentative fraction of the total number of cases. Hence, there is a need for additional search of cases to determine the true geographical extent and magnitude of the problem. So how can we do it? There are two ways. One is active surveillance and another is passive surveillance. What is active surveillance? In active surveillance, the health authorities actively search for information. How do they do it? They collect information from the healthcare providers, from the labs or schools or nursing homes, or by survey or by home visit or by phone call. Okay, then what is my passive surveillance? It begins with healthcare providers or labs initiating the reporting to health authorities. Reportable diseases are submitted on a case by case basis based on the published list of conditions. Okay, so how do we search for cases? There is a process called line listing. Okay, this document is designed to be used as a line list template for investigation of outbreaks of unexplained respiratory illness. So when there is notification of a potential cluster or outbreak, this document can be used to collect and organize preliminary information on cases. Okay, so each case should be assigned an unique ID. Then we collect details about age, sex, onset date, current status, location, case category, epi links, underlying conditions, chest x-ray, specimens collected, testing required, all these. So like all the basic information about the cases we collect with the help of line listing. Okay. So this is an line listing of suspected anthrax. You can see similarly we have taken the onset date, date of diagnosis, age, gender, race, case status, and then what is the presentation. So few key important parameters which are preliminary information is obtained with the help of line listing. Okay. So what have we done till now? We have determined the existence of an outbreak, we have verified the diagnosis, we have defined the case, and we have searched for a case. The next step is to generate hypothesis using descriptive findings. Okay. So we could see that we have collected the basic information of the participants and systematically described the key characteristics of this person. We used these descriptive findings to generate hypothesis. We try to analyze it based on TPP. What is TPP? Time, place and person. This data can be utilized to detect the epidemic, identify the type of epidemic, causative agent responsible to detect the current epidemic, and to take vigorous control measures. To do all these detection, identification, etc., we need to analyze the data with CDC. What is CDC? Here CDC does not mean Center for Disease Control. Rather, C stands for count, D stands for divide, and C again stands for compare. Okay, C is for count. For that, we need to first define the cases to know what to count. D is for divide. We need to divide the population denominator. And C is compare. We need to compare the rates across the group. This summary of data will help us in understanding the characteristics of outbreak, trends over time, geographical distribution, and details of population affected by the disease. All these can be identified. It also helps in identifying the population at risk and provides clues about etiology, sources, and modes of transmission. Okay, so time component. So how are we going to describe the time component? We are going to make use of an important tool called epidemiological curve or epicurve. Okay, so it helps in determining both the magnitude. It helps to determine both the magnitude of outbreak and the time trend. Here, what we can see, we can see both the magnitude and time trend. So these epicurves are very useful basic investigative tools that helps us in order to characterize the outbreak. The shape of the epicurve provides clues about the pattern of spread in the population. We will see how to interpret few epicurves. Okay, so this epicurve, what you can see, there is a steep increase in number of cases and a gradual decrease in the number of cases. Okay, steep upslope and gradual downslope. Okay, this is called a log normal curve and it is characteristic of point source epidemic. Here, the people are exposed to a same source for a brief period of time, that is only once. Okay, next. In this epicurve, you can see the duration of exposure is prolonged and this is a continuous common source epidemic. For example, typhoid Mary. Okay. So here we can see irregular jagged epicurve reflecting the intermittence of exposure. So this is an intermittent common source exposure. Here you can see the series of progressively taller peaks. Here the peak is taller than the previous peak. Similarly, this peak is taller than the previous peak. Okay, which means there is an increasing number of cases in each generation. So this is a propagated epidemic. So what is the use of all these epicurves? It will help us to show where are we in the course of epidemic, and also it helps us in predicting whether more or less cases will occur in the near future. Okay, so we have addressed the time component. Now we are going to describe the place. This why we should do, because the place distribution will help us to give a clue about the type of epidemic, source, and geographical extent. Okay, for this place distribution, spot maps are used. It is simple and basic investigative tools to show the clustering of cases. For example, you can see clustering of cases here, clustering of places here. Okay, it helps in demonstrating the cases within the geographical area, and it also has a major disadvantage. The disadvantage is that it does not take the size of underlying population into account. It simply reflects the cases and does not give a true picture by not reflecting the density of cases. So, in such case, what can we do? We can use something called incidence map. Okay, so this is an incidence map. Before that, you can see a study conducted about dengue outbreak in Varda, showing using spot map to do the place description. Okay, so this is coming back. This is an incidence map. See, if there are 100 cases of malaria in Tamil Nadu versus there are 90 cases of malaria in Goa, then which is more severe? Is Tamil Nadu bad because it has 100 cases? No, because we need to see how many cases are there per lakh population. In other words, we need to see the cases based on the population density. So for this purpose, incidence maps are very useful. And nowadays we have very well developed GIS system, geographical information system, which helps in addressing the where or the place component more effectively. The general reference map can provide situational awareness. It can help in setting up the boundaries of investigation area. It can be instrumental in developing sampling plan. It can help in better planning and team building. It has many advantages. For example, it can be helpful in estimating the underlying population counts and characteristics, to identify the changing behavior, to plan data collection, for better data visualization, for better implementation of preventive and control measures, helps in better communication, and helps in proper allocation of resources. So this GIS has a n number of advantages, and it by itself is a huge topic. So I just wanted to sensitize the viewers about what there is something called GIS, which will be helpful in place distribution. Okay. So what is next? We are going to do person description. Okay. So outbreak assessment by person will provide the description of cases as well as those who are susceptible. Here we will describe about the host characteristics like the age, race, gender, etc., and the details of the possible exposure, that is occupation, diet, medication history, etc. So we do two types of analysis. One is CDC and another is TPP. We have seen what it is. So what next? We need to form the hypothesis. We must try to think about the we must try to think out of the box to correctly identify the contributing factors behind existing outbreak, and we need to rule out the common causes first. Okay, so we will see few important points, okay, in generating an hypothesis. First thing is that we should focus on the outliers. We should give extra attention to the earliest and the latest case on an epidemic curve, and we should interview them. Okay, and then we should determine the source of the similar outbreaks. During hypothesis generation, we should refer the health department records, review the literature, and consult experts to learn about the previous sources. Though new sources frequently occur, knowledge about the similar outbreaks in the past can also be helpful. Okay. Next is conducting interview. So you can conduct a small number of in-depth open-ended interview to identify the possible sources. Okay. We can consider administering something called shotgun questionnaire, which is nothing but it's a questionnaire which asks about hundreds of possible exposure. Okay, this is generally limited. This is generally administered to a limited number of patients for hypothesis generation. And after the generation of hypothesis, we can create a proper questionnaire that is targeted to what is actually needed. Okay, so we have seen the first 5 steps, that is determining the existence of outbreak, verifying the diagnosis, define a case, search for a case, and generate hypothesis. What is our next step? Our next step is to test the hypothesis using analytical studies. Okay, so we have two ways. Okay, one is by contrasting the theories with already established facts, and another is by analytical epidemiological studies to determine the causation and measure the probability of risk. Okay, so when do we test our hypothesis? By contrasting the theories with already established facts. For example, when we'll take a case of hypervitaminosis D in a community. Okay, so you observe that the group of people have hypervitaminosis D. You conduct investigation and you find out that all these affected people buy milk from a particular dairy. Okay, and while inspecting the dairy, you find out that they add more than recommended amounts of vitamin D in milk. Okay, so here it is apparent that this is the reason for outbreak. So whenever the evidences apparently support the hypothesis that the formal hypothesis is unnecessary, then I mean, in other words, like the circumstances are so straightforward and convincing, we use the first method of contrasting the theory. Okay, but in many investigations, unfortunately, circumstances are not as straightforward as what we have discussed now. Okay, so in such case, we use analytical epidemiology. Here we compare the observed pattern against the expected pattern, and we try to use analytical epidemiology to test the hypothesis about causal relationship. Okay, so if we are going to conduct epidemiological studies, it is essential to learn about the study designs. Okay, and when should we design a study? As you know, conducting a study is time intensive and resource intensive. Hence, it's always ideal to generate hypothesis first before designing a study, and this will help us to clarify our study objectives and enable us to ask better questions. Okay, so which is the best study design? You can say RCTs are the best study designs, but however, it is not possible in outbreak investigations to conduct an RCT. Hence, we mostly rely on observational studies. We commonly use three types of studies. One is cohort, another is case control, and another is case. In cohort can be prospective or retrospective. Okay, so the retrospective cohort is commonly used. Okay, especially when a population affected is often well defined and available for enrollment. Like in the first case scenario, yesterday you had chicken biryani in the mess. Okay, so you know who all ate chicken biryani in your mess, and most of them are your friends. So here we know the population is well defined and available for enrollment. So in such case, cohort study is best to do. Here what we do, we elicit the exposure history and compare the disease incidence among persons with different exposures or different exposure levels. Okay, whereas in case study, we'll be conducting it when conducting a cohort study is not possible. For example, when we don't have a defined cohort or there are too many non-ill persons in the group interview, then we use case control study. Here the direction of inquiry is from outcome to exposure because this is a case control study and it's the most commonly used study design. Next is case study, which is similar to case control study, but here instead of control we have a case, but it is a case of some other illness which is not relevant to this investigation. Okay. So in cohort study, we calculate the risk ratio, which is the incidence among exposed by incidence among unexposed. Whereas in case control study, we calculate the odds ratio, which is odds of exposure in cases divided by odds of exposure in controls. You might think this retrospective cohort and case control seems to be same. No, but there is a difference because the cohort study allows us to determine the incidence of disease among the cohort, whereas a case control will help us to determine the percentage of exposure among the case and control. So there's a fine difference between retrospective cohort and case control studies. Okay. So again, highlighting the key differences between the different study designs. Okay. The sample size is relatively larger in retrospective cohort, whereas it's smaller in case control. So since there is a large sample size, the cost involved is more in retrospective cohort, whereas it is less in case control and case. Okay. If the exposure is rare, then retrospective cohort is better because in cohort study, the direction of inquiry is from exposure to outcome. Whereas if the disease is rare, then case control is better because the direction of inquiry is from outcome to exposure. Okay. Similarly, since we are going to proceed from exposure to outcome, even if the patient have multiple outcomes, we can examine with the help of cohort studies and the natural history of these disease can be known. Okay, similarly, the risk of developing a disease can also be ascertained with the help of cohort studies. Okay, as I said, the main disadvantage with cohort is that we need to have well-defined population and that population should be available for enrollment. Hence, when that is not there, then it is better to go with case control or case studies. Okay, so what all we have seen? We have seen the determinants of existence of an outbreak, verification of a diagnosis, defining a case, searching for a case, generating hypothesis, testing the hypothesis, and our next step is to draw conclusion. Okay, so we draw results based on interpreting the results of analytical studies, such as whether the suspected exposure is associated with illness, what is the strength of association, is there any statistical significance, is there any dose response relationship. Lab findings are also helpful in describing the conclusions. For example, let us take this food poisoning outbreak here, okay, which had here you can see different food items are served, and among all this, 53 people who ate beef became ill, and 28 people who ate beef did not become ill. Similarly, 4% of those who did not eat beef became ill, and 31% so who did not eat beef did not become ill. Okay, so we are going to calculate the attack rates here. Okay, so the attack rate here is 65.4%, which is nothing but number of people who fell sick divided by the total number of people who ate beef. Okay, which is 65.5. Similarly, for those who did not eat beef, the attack rate is 11.4 and the overall attack rate is 49.1. Okay, so we are calculating the risk ratio, which is coming out to be 5.7, and we are going to calculate the population attributable risk, which is nothing but attack rate in total population minus attack rate in an exposed group divided by attack rate in total population, which comes out to be 76.7. You might ask me, you're telling too many numbers. What are all these? Okay, I'll explain it to you simply. This means that the proportion of illness, that is 76.7 percentage of food poisoning in the study population, can be attributed to eating beef. Okay, so 76.7% of food poisoning is due to eating beef. Okay, so this kind of logical conclusions can be derived when we are doing analytical studies. Okay, so the next step is to compare the hypothesis with established facts. Okay, the hypothesis that explains the epidemic must be consistent with all the facts the epidemiologist has observed. If not, then we should re-examine. This is what CDs is also recommending, to re-verify or reconfirm the generated hypothesis. Okay. So our purpose is not only to strengthen the speculation, but explain the cases at the peak of the pandemic. So this thing we should keep at our mind. Okay. So we have seen the first 8 steps. The next step is to communicate the findings. Okay. We need to develop communication plan, and we need to communicate properly and in a timely manner. For example, during COVID pandemic, awareness about social distancing, awareness about vaccine, all these were given wonderfully through IVR by the Indian government. Similarly, whenever there is an outbreak or epidemic, appropriate strategy should be formed to communicate the findings to all the stakeholders. Okay, and after communication, the final task is to as a part of communication, the final task is to summarize the investigations, findings, and communicate the report effectively for preventive action. It includes not only oral briefing or not only written reports, we should give both oral briefing and written reports to all the stakeholders. For example, this is a reporting format of Kala-Azar. I have just showing this to sensitize the viewers that there is something called reporting format, which is different for different diseases. Okay, here you can see details about outbreak location, source of alert, criteria for defining it as an outbreak, what are the different parameters, what are the entomological survey parameters, what are the outcomes. So all these are there. Okay, so this kind of report should be submitted to all the stakeholders and communicated to them appropriately. So the last step is to execute preventive measures. We need to execute standard control measures even before the results of investigations are available. For example, we should start giving safe drinking water to all the villages in waterborne disease outbreak. While executing preventive measures, we need to follow good recommendations. Okay. So what is my good recommendations? Good recommendations are those that are evidence-based, feasible, cost-effective, and acceptive and specific. Okay. Let us take the example of Sputnik versus Covaxin. Okay, which is a good recommendation. So, evidence based. Is Sputnik evidence based? Yes. Is Covaxin evidence based? Yes. Next is specific. Is Sputnik specific to COVID? Yes. Is Covaxin specific? Yes. So, 2 out of 2. Feasibility. Is Sputnik available everywhere? Well, not very commonly, whereas Covaxin is available commonly. Similarly, cost effectiveness. Sputnik is paid, whereas Covaxin is free. And then acceptability. Covaxin definitely has better acceptance because it's an indigenous vaccine. So, considering all these points, Covaxin is a good recommendation. Maybe scientifically, Sputnik can be better, or a different vaccine can be better, a little bit better than the other vaccine. But when we consider all the other things like feasibility, cost effectiveness, and acceptance, covaxin is definitely better. So we also need to implement the short, medium, and long term preventive measures. We should have a proper strategy. What should be done in short term, what should be done in medium term, and what should be done in long term. Okay. For example, if in case of cholera outbreak, if well is a source of infection, then our short term preventive measure would be to prevent access to that well. And the mid-term preventive measure would be to protect the well. And the long-term preventive measure is to ensure that all the new wells which are going to be built are protected. Okay. So I'll just shortly summarize all the 10 steps. The first step is to determine the existence of an outbreak. Second step is to verify the diagnosis. Then we define a case. Then we search for a case. Then we generate hypotheses using descriptive findings. Then we test the hypothesis based on analytical study. We draw conclusions. We compare the hypothesis with established fact. We communicate the findings and execute the preventive measures. Okay. So in the field of outbreak reporting and investigation, IDSP is playing a key role. Okay, Integrated Disease Surveillance Project, it consists of a surveillance team and rapid response team at district level to help in quick management of outbreak. It's functional since 2000 year. You can see this is one of the recent reports of IDSP from in the month of June 2022, which shows the details of the various outbreaks across the country. Similarly, NCDC and WHO is also playing a vital role in enhancing the capabilities for rapid response team to outbreak and lab surveillance. Okay. So this is in short about investigation of an outbreak. My sources were from CDC, Leon Goddess, IAPSM textbook, and few reference research papers. Okay. So thank you so much, everyone. We'll catch up in another video.